Thank you so much for joining us today. Gonna let a few more seconds, let everyone kind of trickle in, and then we're gonna get started. A lot of great content for you all. All right. Well, as people are joining, I'm going to get us started. Saying thank you so much for attending today. Our session is on integrated mental health. We have some great presenters today, some great content. I'm really excited. But before we go into anything further, I did just want to give a few reminders. So you can hear us. We can't hear you. We can't see you. So everyone's in listen only mode. If you want to ask a question during the session, there is that Q&A button on the bottom of the screen. You can click on that. You can ask questions. You can do that throughout the presentation, but also we will have a designated portion at the end of the webinar to kind of go through some of those questions. To turn on closed captioning, click on that CC button. Depending on your version of Zoom, it might be different. It might say CC, it might say closed captions. Please complete the evaluation poll questions at the end of the presentation. Those are so helpful for us to kind of gauge where the people in the field are at, what we need to do, how we can develop our content, and how we can deliver it in a better way, in a more supportive way. And then finally, the recording, the slides, and any resources shared will be uploaded to the School-Based Health Alliance website, but also emailed out within a week or so. So you might be familiar with us, but if not, we are the School-Based Health Alliance, which is a DC-based nonprofit that was founded in 1995 and serves as the national voice for school-based healthcare. Our board of directors reflects a wide variety of perspectives from across the country, including health centers, hospital leaders, state and regional partners, community partners, and even youth representatives. So this work is supported by the Bureau of Primary Healthcare, and as a National Training and Technical Assistance Partner, or NTAP, the School-Based Health Alliance provides training, technical assistance, and resources to support school-based healthcare programs nationwide. At its core, school-based healthcare brings services directly to students where they spend the majority of their time, in schools. So our learning objectives today that we really hope that you'll be able to take away and understand from the content is that be able to define at least 3 core components of integrated mental health in school-based settings, differentiate between co-location and operational integration in school-based settings, and then identify at least 2 structural or workflow decisions that health centers could strengthen to improve integration in schools. Before we go any further, I do want to stop and let everyone introduce themselves. My name is Donnie Greco. I'm an associate, like I said, and I'm going to pass it over to Addie. Addie, take it away.
Hi, everyone. My name is Addie Vanswell. I'm a vice president at the School-Based Health Alliance. I've been here for about 3 years, just over 3 years. But prior to that, I spent time working as a manager of behavioral health in a school-based health center just outside of Chicago. Amy?
Hello, everybody. My name is Amy Hill. I'm the Executive Vice President for School-Based Services for Centerstone. I spent most of my career working in school mental health over the last 20 years in some way, shape, or form. Just recently merged with Centerstone. I've worked for this organization for almost 9 years. We've gone through an iteration of mergers and acquisitions, and we're now Centerstone. So excited to talk about this work today.
Good afternoon, everybody. My name is Trisha Wan. I'm the clinical manager over our behavioral health clinicians based in our school settings here at Cherry Health in the West Michigan area. I've been in this role for the past 3 years and been doing youth mental health in some capacity, both clinically and in leadership spaces for nearly 20 years.
All right. Thank you very much, everyone. So with that, I'm going to pass it to Addie, who's going to kind of get us started on why integrated mental health in school matters. Addie?
Awesome. Thank you, Donnie. So yeah, we are going to spend a few minutes just kind of getting everybody with kind of baseline understanding of what we're talking about here. So integrated mental health in schools matters a lot for school-based health centers and for health centers because it's really talking about providing services in schools, not just relocating the care there, but that it actually requires this intentional integration. So, youth mental health needs, as we all know, continues to rise pretty steadily across the United States. Schools are where students spend the most of their time. So it makes it really easy access point to be able to meet students where they are and provide those mental health services. Health centers are expanding services into school settings. And it can be kind of tricky. So really understanding how to do that and how to do it well is incredibly important. And then delivering care in schools requires operational adaptation. So, what you may do at your local community health center, you may not be able to do the same things as far as how the operational pieces are figured. So one example I can give is maybe the number of patients you see per day might be a little higher in the community setting, whereas the school you might have just based on hours of operation or needs of the students, you may not have as high of a caseload. So there's a lot of kind of coordination and collaboration with school partners, primary care providers, and so all of that is kind of taken into consideration when we're thinking about workload. We'll go to the next slide to talk a little bit more about what we actually mean when I say integrated mental health. So this is really kind of coordinating that care between primary health care and behavioral health services. And I'm not just saying co-location. So co-location does not equal integration. As many of you probably know, you can have an office right next to each other, but if you're not actually, actively talking through cases and really working through kind of the needs of the student, that doesn't really work all that well, right? So you need that intentional collaboration, you need that time, you need that space to be able to talk to one another. It really is, like I said, that shared communication piece, having those warm handoffs, and clearly defined referral pathways. So you may be working in a school that also partners with three other organizations, right? And so I think that's also important to think about when we talk about referral pathways of like who gets referred to who and how and why and when, right? So really having those clear pathways is incredibly important. I also will speak to the warm handoff piece in it's really helpful to be able to say, if Donnie came in for a medical visit and he had some stressors going on, and the medical provider was like, hey, I really think I need you to meet Amy, right? Like, and then that provider is able to walk Donnie down to Amy's office and say, like, hey, this is Amy. She may not be available right at this moment to meet with you, but let's schedule some time for, maybe later this week, next week, whenever the first available appointment is, if it's not urgent. Having kind of shared care planning. So, not having all of the weight on you as a behavioral health provider, but to really lean on your medical colleagues and partners to come up with a shared care plan for the students. And then just that ongoing collaboration among and across disciplines. So, really, I had a lot of students that would come in for behavioral health services. And then as we're talking, I'm realizing, like, oh, you actually haven't had a well child visit in like 3 years. Let's figure that out. Let's get you over to my medical partner. Or, oh, hey, you are in need of your vaccine that you hadn't received yet. Like, let's make sure we get that appointment, right? And so I think allowing for that open communication and ongoing collaboration across the disciplines is really helpful. Next slide. So as I kind of alluded to a little bit, we have this kind of transition from kind of traditional care to what integrated care looks like. So in the traditional setting, you have your medical services and your behavioral health services operating very separately. Whereas integrated, you're co-located and you're completely embedded. So you are working together hand in hand. You're talking every day, you're collaborating. In the traditional setting, it might be really hard for that provider communication. It's a whole lot easier for me to go down the hall and say, hey, Amy, I need to talk to you about this student versus picking up the phone call, which is possible, right? But it's just so much more natural to be able to do that when you are located in the same space. Referrals sometimes can get hard too if you're working in an outpatient setting. You obviously have your referral sources and you have, you might have a community health worker or a care coordinator that can kind of help with that. But with integrated care, what we're really seeing is those warm handoffs and those shared workflows. There may, in the traditional space, be a little bit of a delay in access to care. So, you may have, I know I was in the Chicagoland area, I was trying to coordinate psychiatry for just a family friend. I was calling around and being a person in the behavioral health field, knew exactly what to ask. I knew exactly um, how the system was set up. And I was being told like, well, we might have an appointment in a year. Well, that student is kind of in crisis now and really needs that support now. So with integrated care teams, I think it does set it up nicely to be able to access that service maybe a little sooner. And then, of course, that last piece around fragmented treatment planning. I think this speaks to the point of like when you are working together in an integrated care model, you really are working together and coordinating that treatment planning versus having to try to figure it out from your individual offices and 3 or 4 or 5 phone calls later, right? Like you are actually there in the team working together to move things forward. Next slide. So, there are many reasons why this matters for health center operations. This is definitely not an exhaustive list. But as you can see here, improved communication, access to care improves, being able to early identify issues and provide that kind of on the spot intervention, looking at the whole child, using a holistic approach, really having a direct impact on academic performance, and then building those partnerships between schools and their communities. So I think another important thing to highlight is how integration can be different in terms of school-based health integration and how operations happen, right? So you're dealing things with like school schedules, academic calendars. I can't tell you the number of times where I had like an entire list of patients that I was ready to see, and then I go in that day and I'm like, oh, it's SAT testing, like that's not going to work, right? So kind of being able to navigate around that. There are some considerations around FERPA, so the education protections as well as HIPAA, and making sure that you're staying in line with HIPAA and FERPA as the providers. We do have a resource guide that we had published a couple years ago. We can drop the link in the chat, but it's a pretty comprehensive information sharing and confidentiality protection guide. And so it highlights a lot of really good examples. So definitely encourage you to take a look there. As a behavioral health provider, you may be part of that school crisis protocol or be part of those safety teams. I know I was, right? So making sure that we're supporting not only the students that we're working with, but also kind of the broader at like the school level or district level, even in kind of influencing policy and talking through some of those crisis protocols. You're also managing referral pathways from teachers and counselors. So I had a good friend who was an English teacher, and she would send so many students my direction, either for behavioral health or medical, because she knew we were there to support the whole child. So I think one day she was like, I think half my room has strep throat. Can you do something about that? And so I was like, yes, just send them on down, right? And so we were able to kind of meet the needs where they were at. And then you're also going to have kind of shared spaces, staffing constraints. I often wore 3, 4, 5 different hats working in the school-based health center, and just kind of recognizing the different roles, different responsibilities, and then also navigating space. Next slide. So, I think what is really important here to think about is, and these are some questions that you can kind of ask if you're thinking about moving into schools. So, and how this can be different or similar to what you already do. So, how you're capturing those referrals. Are the warm handoffs built into your workflows? Who is supervising a behavioral health clinician? So I think that was one thing that I saw when I first started that I was like, who's my supervisor, right? Like I was operating as an independent licensed clinical social worker. And so I had to figure out like, who do I go to get some additional guidance, support, supervision, right? Are you having regular case reviews or huddles? And then how are you working with the school teams on crisis protocols and procedures? Next slide. So as you kind of hear from our guest presenters today, you're going to hear perspectives on school-based mental health services across different school contexts, and a perspective on integrated mental health within a school-based health center model. So as you listen, I would encourage you to kind of think through these 3 questions. So where does integration happen naturally? Where does it require deliberate effort? I think I highlighted some of those already. And then also what structures currently support sustainability. So with that, I think I will pass things along to Amy so she can talk about her work at Centerstone.
Thanks so much, Addie. So, yeah, I'm going to spend quite a bit of my time talking about my work here related to specifically mental health services. I should have mentioned earlier, Centerstone, we are a really large nonprofit behavioral health organization. So, we're in multiple states. We're in Missouri, Illinois, Indiana, Tennessee, Florida, and then a little bit in Kansas and a little bit in Oklahoma. And we are primarily behavioral health, but we do have some FQ clinics and a couple of school-based health center sites as well. And so I really just have the opportunity to work across our whole system and in multiple states when it comes to school-based healthcare. But today I'm primarily going to focus quite a bit on the school-based mental health side. So you can go to the next slide. I want to visit a little bit specifically about the delivery of school-based mental health services. So I'm going to talk about it from both a clinical provider perspective, but also from a leader or a manager perspective. And so Addie, you heard Addie talk a little bit about being a provider. I also was just I was a clinical provider in a school setting for many years before I moved into leadership and focused more kind of on the leadership level. And so these are some things that I learned as a clinical provider, but also really work with our clinical providers quite a bit as they're out there delivering those services as well. So I think one thing that's really important to remember is that we really have to integrate our services, understanding the uniqueness of culture and climate in each school. So even as you're working with some districts, like many of you, we work with some really small districts that might have 200 kids, K through 12, and we work with some really large districts that have 50,000 plus students, K through 12 in them. And each building is a little bit different, and the dynamics and the culture and the climate of each school is different also. So I absolutely believe as a clinical provider, we have to be able to integrate our services that match that particular culture and climate of each school. So I think it's important to keep that in mind. Another thing that I really encourage people to understand is that as you're walking in here as health providers, mental health providers, oftentimes our perspective, our philosophy, you're going to hear me mention this a couple of times today, can be very different from the educators that we're working with. We have mental health education and experience. They have, they went to school for education, and oftentimes those are 2 very different philosophies. In the end, I think everyone cares a lot about kids and wants to see kids be successful. And this is why I think it's important for us as providers to understand that a lot of our role is to try to help bridge that gap, bridge the understanding and those perspectives of the 2 different things, and just kind of know that whenever you're going into those settings. Another thing I've heard a lot of schools ask questions about over the years. A lot of our school partners have asked us, like, how do we know if your services are working? Frequently we'll refer a kid to treatment and then we just never hear anything else about it. We don't know if they're getting better or not. We maybe see some progress in some areas, sometimes we don't. I think it's very important to deliver measurable clinical outcomes. And so be really clear about how you're going to measure your success. Of course, one great way to do that is through goal-driven treatment plans, having SMART goals and those measurable goals. But use other outcome measures as well, like screeners. You can use GAD screeners, you can use PHQ-9s. There's a lot of different things that you can do to try to help measure the success of your clinical work, to be able to report back to the school district and say, hey, we saw 27 kids in your district and 15 of them report an improvement in their anxiety symptoms through these sorts of screeners and measures that we used. So I'm always really particular about our providers engaging in those measurable clinical outcomes, sharing those. I also want to pause for just a second and say, not only is that super important, in my opinion, for our school partners, but I also think it's equally important for our providers, because oftentimes I remember those days when I was in the trenches day after day after day working with kids and wondering if what I'm doing matters. Sometimes it's really hard to see the success as you're doing those daily incremental things. When you can look back on your clinical outcomes and you can look back on those treatment plan goals and be able to identify the success, it can be really encouraging and motivating for our providers as well. We certainly want to align our treatment plan goals through ongoing collaboration with school staff. So, I always think about and communicate with our school partners that, listen, we aren't treating school related issues. We are treating mental health concerns in the school setting. And oftentimes those things can be very confusing. Sometimes educators might think we're there to just address issues that happen at school, but really we're not. We're there to address the students' mental health. Because as Addie already mentioned, they spend the majority of their time, kids spend the majority of their time in a school setting. And we know through research that 80% of all kids who are ever going to receive a mental health intervention are going to do so within the four walls of a school building. And that's why it's very important that we really focus those treatment plan goals on their mental illness, but also work with the school staff on how their mental illness is impacting their success, both academically and behaviorally in the school setting, and collaboratively establish some of those treatment plan goals and objectives that we want to work for. And then we do want to be very responsive and have some sort of a team-based support during a student crisis. Student crises are very, very important to educators across the nation right now. We're seeing a lot of superintendents continue to report concerns about student mental health. Addie mentioned that. There's a lot of concerns about student safety that can be directly tied to student mental health. And so being able to be responsive, to show up and do the things that we say that we're going to do, and to be team-based during a student crisis not only helps our partnership with the school district, but allows us to provide the best care for clients when they are struggling with those crises. So the next slide really talks about how do we manage this? And so I appreciate that Addie threw in there, like, who's my supervisor? Like, who do I go to for support? As we have providers that are fully embedded in schools, they don't work for the school. They work for either themselves or most likely another organization, yet they really become a part of that culture at that school. Those are their coworkers. They show up there day in and day out, and they get to know the educators oftentimes better than they get to know their own coworkers, because they're out in these buildings. They're embedded. They're not necessarily right down the hallway from their supervisor. So I think it's very important for managers to be great support for our staff, but also be great support for the school, to where we can kind of keep that collaboration and communication going. So here's just a few tips for how I have seen us be successful in order to maintain that relationship with our schools. And so we really want to establish strong partnerships through clear expectations and formalized MOUs. It's one thing to just say, oh, we're just going to show up, or, we're going to come in and see kids in and out. And that can become very confusing and conflicting for both our school partners and our students if we don't really have clear expectations about what this is going to look like. And we always use a formalized MOU. One thing I also recommend is that you pay attention to your MOUs. I've been reviewing some contracts recently that I might hear from somebody, oh, this is the most up-to-date contract we have with the school district, and it was signed in 2023. Well, let's revisit those. Let's see what has changed since 2023. Let's make sure that we have those formalized MOUs that can allow us to be in there and everybody understands what to do. I also highly recommend that you develop some kind of a streamlined internal workflow that's user friendly for the school to make referrals. I can't tell you how many times I've heard over the years from school partners, I referred Johnny for treatment. I've never heard another thing since then. Oftentimes, we really neglect to close that communication loop. And what I have found is that when you have a really great workflow process that you do day after day after day, really paying attention to the referrals that are coming in, closing that communication loop with the school district, that's when you tend to get more referrals. You tend to see school districts identify more and more kids in need and send referrals. Again, if they send referrals and they never know what happens with them, they're highly unlikely to continue to send more referrals. They might really be looking for somebody that they know is going to meet their need. And so the best way to do that is to just have a well-developed workflow, in my opinion. Again, I mentioned closing that communication loop by providing consistent updates on referrals. If a school district has referred Johnny to me 4 months ago and I still haven't been able to get Johnny into treatment, I need to explain to the school why. I need to be able to say, I've called Johnny's mom 4 times and I'm not getting a return phone call, or I had an assessment scheduled and they didn't show up, or they declined services altogether. They don't want them. Being able to communicate that back on a very consistent, updated schedule allows your school partners to see you as somebody they can really count on. You're dependable, and they know that they can trust that you're saying and doing the things that they have expected you to do, with that step one and establishing those expectations. You want to maintain that ongoing structured collaboration with school teams. The best way I have found to do that is to just have a consistent meeting set up, a consistent schedule when you're going to collaborate and you're going to connect with the school people. I really like for that to be a diverse group, right? It's pretty common for us to communicate very regularly with the school counselor or the social worker. That just organically makes a lot of sense. But it's also important to communicate with administrators or school administrative assistants. Any sort of person that can play an active role in that client's treatment is also should be a part of that collaboration and a part of that conversation as you're working with your school teams. You really want to know what your appropriate staffing ratio should be. You want to define that ahead of time, and then you really want to uphold and stick to that as much as possible. Listen, I know we are all struggling with workforce development. I know we will always, at Centerstone, you will always be able to find an open school-based position on Indeed or on our website. We will never be fully staffed because we do have a workforce shortage, but it's very important for us to be really clear and define with the school districts what that ratio is going to look like. We are pretty particular. We can have that down to a science, how many clients we know our providers can see and provide good care. We talk about that initially right out the gate with our school partners. I don't typically promise every building a full-time provider if every building doesn't have the work for a full-time provider. And so we really have that conversation, define those at the very beginning, again, with that idea of quality service connected to that staffing ratio. And then we want to provide that high quality care through robust clinical supervision and oversight. I mentioned earlier that these providers are oftentimes on their own. Sometimes what I hear from our staff is they feel like a man on an island from time to time because they're out in the schools and they can't just walk down the hallway and talk to their supervisor. So we need to make sure that we've got great clinical supervision ready and available for our embedded providers. They can call, they can connect. We don't miss those supervision meetings. We staff cases with them. We provide that oversight. We know when they're at the school and when they aren't. We never want to hear from a school partner, hey, I haven't seen your provider for the last 3 weeks and we don't know what they've been doing. And so it's really important that we provide that high level of clinical supervision to just help our providers be successful. And again, we're really looking to maintain credibility and trust with our school partners throughout the course of the school year. So let's talk about some key considerations, some things that you're going to want to consider as you're creating or developing some of your programs. You certainly want to design your service model that's going to align with the school day. So this is going to look like shorter, more frequent sessions. A 50-minute outpatient therapy session just is not conducive to the learning environment in a school setting. And so we really sometimes have to think about how can we be just as successful, yet accommodate the school setting, the learning environment. And oftentimes, like I said, that looks like you might meet a couple of times a week instead of once a week, but they're shorter sessions. You want to structure your caseloads that are going to both support access to care and financial stability. We understand there is this level of business acumen we have to have as providers in order to make sure we're able to continue to work as well. And so you want to be particular about how you structure your caseloads to help your providers be successful, allow kids to get in and out of treatment, and not just sit on a wait list forever, waiting on somebody to come in and help them. I really love the idea of incorporating group therapy when it's clinically appropriate. All the research and data, all the data on group therapy really indicates it's just as effective as individual therapy. And in a school setting, group therapy might seem like it doesn't make sense, but it makes perfect sense because it's exactly how kids learn as well. They do a lot of group work throughout the course of their day when it comes to academic instruction. And so why not incorporate group therapy into your service model as you're working with kiddos? It's a perfect place to do specific groups like working on ADHD skills or a divorced kids care group. There's a variety of groups that you could really provide in the school setting that will allow students to receive additional layers of support and service through a different modality that is just as effective. And then you want to be sure that you're evaluating those caseloads, that you're evaluating the demand before, like I mentioned, before you just go in and put in a full-time provider. I will also say, we learn this lesson the hard way sometimes, is that a caseload can quickly get out of control in a school setting when you're a great partner. When these schools start to recognize that when they make referrals, you're going to get them in, you might notice suddenly you've got more referrals than you can deal with, and your provider's caseloads got out of control really quick. And so you want to monitor them for both of those areas. You want to really monitor your projected caseloads prior to just saying you can have a full-time provider in every building. And you want to try to stay on top of what those caseloads look like for your providers to where they can provide good care and not get overwhelmed as well. And there's some additional key considerations on the next slide. So you are going to want to implement structured onboarding workflows with consistent partner communication. So when you're bringing on new schools and you're bringing on new partners, or new providers, it's very important that you know what that onboarding workflow is going to look like. You know who's going to be making referrals. School counselors know exactly how to do that. And I don't really have this spelled out on here, but part of onboarding is bringing in new providers and making sure that they understand what it looks like to work in a school setting. It is very different being a school-based mental health provider than an outpatient therapist. It's very different. And so it requires some different training and different onboarding initially. And you want to make sure that they also understand what those workflows are because they're the ones in the buildings that are going to be receiving the questions and need the communication. We always have to talk about diversifying our funding streams, right? Every state is different. Every community is different. There are so many different types of funding streams out there, whether it's billing insurance or it's looking for grants or it's MOUs where school districts covers part of the cost of your program. And so you really want to make sure you've got a variety of ways that you are able to ensure your program stability, not just relying specifically, for example, on grants only or specifically on MOU contracts with schools. You want to make sure that if something were to happen to that today, you can ensure that your kids are still those kids are still going to get the treatment that they need. And another way you can consider this is exploring those alternative payment models like a PPM arrangement, a per member per month arrangement with school districts. I've heard of a lot of places doing that as well, just to ensure that all kids, regardless of funding, are able to receive some help. So let's talk about common challenges that people experience. I mentioned this earlier. It's always the top challenge that comes to mind for me whenever I think about my work in schools. And that really is just balancing that different philosophy when we're advocating for students. I know many days when I would walk through a school building and a teacher would see me, their first thought was, oh, here comes that girl who's always on the kids' side. I know that that's what they thought all the time, that she's always on the kids' side. And so I think really understanding that difference in philosophy is so important for our providers as they're advocating for students. The student is our client, yet we are guests on these people's property. We have to remember that. We are guests on their property, that they welcome us in to try to serve students, and we have to approach our collaborative conversations, particularly not if, But when there is a situation that is difficult for a student, maybe the relationship with the teacher and the student isn't good, and we need to go advocate for that student, we have to understand the educational philosophy, what their thoughts are, and we have to respect that as we go into those conversations. So being aware of the difference in philosophies is so very important, and have some skills in having difficult conversations and communication as you're approaching those, because we always want to keep the student as our client, but advocate with the teachers and the staff. We want them to see us as a partner and just some girl who's always on the kid's side. Adapt some creativity when you're talking about space in schools. Space, most of the time, is a luxury when it comes to these school buildings. We work with thousands of schools at this point at Centerstone, and I could probably tell you 10 of them that have all the space that they need and then some. Most schools really struggle with space, and so you might have to get creative. Recently, we've got a partner in one of our states. We've got a group of providers and a leader in one of our states who created Lego rooms. She ordered these gigantic Legos, built a Lego room just to be able to have some space inside another, like a HIPAA compliant space inside an area in a school where there was just no ability to build walls there at the time. So sometimes you have to get creative because we know that space is a struggle, but it's still really important that kids have access to treatment. You want to strengthen that parent engagement through coordinated outreach. I wish that I could say that every parent we work with is engaged in treatment. It's just simply not true. The beauty about bringing services to kids in schools is that it allows under-resourced students to get the needs that they have met, right? I always say I'm a mama for my kids are resourced, and it would still be difficult for me to take off work every single week to take my kid to an outpatient therapy session, but I could do it if I had to, right? But a lot of parents cannot. And so we really have to work on strengthening that parent engagement, have that coordinated outreach with both the school district and yourself. And then really collaborate with school teams on home visits when needed. Oftentimes, when we've really struggled to get a hold of a parent and the school has said, this is our number one concern, we really need to get this kiddo into treatment, we'll go with the social worker or school social worker to the house to try to meet with the parent to do what we can to try to get the kid into treatment. And so those are just some common challenges I think we're going to experience everywhere or probably never go away. But it's our job as providers to just try to work through some of those. So let me talk for just a little bit about CCBHC. I live in both kind of spaces. Several of the states that I work in have CCBHC status, and then some of them do not. And so I'll talk a little bit about a school-based mental health model that does align with CCBHC, with the CCBHC status. And so when you're looking at those sorts of schools, those sorts of states or wherever you might be funding, the primary focus there really is just focusing on addressing that student behavioral need. And clinicians tend to be employed and managed by the community behavioral health clinic, not by the school district or not just out in individual practice. The school serves as that primary site of service delivery. That is where those providers work. They are embedded in those schools. And there's a really strong emphasis on using evidence-based practices. I will tell you, I sat with a provider and watched them when I was doing a ride along, watched them provide EMDR services to a kiddo in a middle school. Really focusing in on motivational interviewing, TFCBT, EMDR, CBT, all of those evidence-based practices is very important in the CCBHC world. And so making sure our providers are trained and have access to learning those evidence-based practices are really important. And then there's also really an emphasis on access. I mentioned earlier, kids sitting on a wait list in a CCBHC model. We really have to focus on access. We really need to be able to provide access to treatment regardless of the circumstances. And there's care coordination that happens along there, making sure our clients are connected at multiple levels, multiple services that they might need, and then also the quality measurement. I mentioned earlier using those quality metrics and measurements within the school setting is so very important. And there's quite a bit of emphasis on that in the CCBHC aligned model also. I'm going to talk just briefly about the school-based health center model. That is not necessarily my area of expertise. I know you're hearing from other people on this call who really can talk about that, but here the primary focus is on that medical care with integrated behavioral health services. That's kind of a big difference between the CCBHC and the SBHC model. They tend to be sponsored and operated by healthcare systems. Schools provide that space for that partnership support, and your behavioral health staff might be embedded within that medical model as opposed to just kind of standing alone on their own. It's not necessarily governed by a single national standard, which is what the CCVHC criteria is. I think, is that the end for me? I'm pretty sure that's the end of my slide. So I'll pass it on to, am I passing it to you, Addie?
No, I think we'll just hop right on over to Trisha.
Perfect. Thank you. So I'm going to reiterate some of the things that both Amy and Addie have already talked about, maybe give a little bit of a different perspective. Our services are delivered in a couple of different ways. So we'll talk about how Cherry Health operates services and a little bit more, expand on a little bit more of what Amy had talked about. So just kind of a reintroduction. Like as I said, I'm a clinical manager over our school-based health center programs here in Cherry Health in West Michigan area. In Michigan, we are the largest health center, serving over 57,000 patients across more than 20 locations in 6 counties. We maintain 4 school-based health centers that deliver medical, mental health, and some of them also have dental services. And then we have 4, the model here is called E3, school spaces, which is just a mental health provider integrated into the school. So they don't have a health center, they just have an office, it's them. And then they have a half-time community health worker that supports some of their various functions as well. So when I said that I would speak to you all, I originally had talked to my staff and wanted to have one of them present to you and give you a little bit different perspective, and they're all very shy. And so really, we're not open to doing a presentation. And I also think that this work is really important. So I wanted to be able to, you know, share their voice and share from their perspective. So some of this really is, you know, from my perspective as a clinical manager and some of the work that I've done in a school and working with youth in general. But all of this was vetted through my staff who are doing the work day in, day out. You know, as Amy had mentioned, they really are the person on the ground. I don't get to work in all 8 of our schools with them. I can't be in all those places all at once. And so they have a level of really independent work, and there's a high level of trust between me and my provider team, and then also between the school and our agency, that these staff really are going to provide high level care and get the job done that we've agreed that we're going to do. So I asked them originally, I said, you know, what do we do? So who are we? What do we do? Why do we do what we do? So all of them talked a lot about this. They just enjoy working with youth, and they believe that meeting youth where they're at in their spaces leads to better engagement and greater outcomes. So kind of mimicking what's already been talked about, having easier access to students, knowing where to find them, knowing how to find them, not counting on having to pull them out of school for 3 hours for a mental health appointment, being able to see them maybe for 30 minutes. So really maximizes their ability to get to us and to receive that quality care without cutting into their school day. They find that the work with students is really fulfilling, and oftentimes, you know, students are within any one building for sometimes 2 years, sometimes 3 years, sometimes 4 years. And sometimes we are fortunate enough to see those students at the start of their educational career in that building. And we kind of get to grow, you know, see them grow and develop over time and support them throughout different phases of their development. And that feels very promising. When we do a good job, students oftentimes refer their friends to us, and they bring friends down, they bring other students down, and they say like, hey, this is Miss Amy, hey, this is Miss Addie, I need you to come meet this person, or hey, my friend really needs some help too. And so they find that that's really validating, you know, of the services that they're providing. But then we also know that we're doing the job that we said that we're going to do, and students and parents and teachers trust us to continue making those referrals. We find that it's really important to keep our spaces very judgment-free and youth-friendly. That really creates a sense of openness and honesty from students. We take that feedback from them about our space and the services we provide very seriously. If it doesn't feel open, if it doesn't feel safe, it doesn't feel supportive, students aren't going to come and see this, and they're not going to benefit from their services. Our staff talk a lot about how students really just have the autonomy to openly discuss things that maybe they don't discuss in other spaces. We find that kids are often much more honest and engaging in these spaces. As Addie mentioned, students spend most of their time in the school. So it's not a highly clinical environment, where there's lots of other offices and lots of other adults and lots of other people. We have a safe space kind of carved out, and that really leads to very genuine, honest engagement from students, and sometimes being able to address issues that wouldn't be able to be addressed in other spaces, which does also include having them, be open about other needs, and being able to connect them to those other services. So dental services, primary care services, things like that. And then the ability to offer a variety of things to them in the same space. Some of the benefits of working in a school-based health center. Some of our clinics are full clinic models, which allow for just a greater presence, greater visibility, more referrals. When students are referred for one reason, oftentimes as we get to know them, we will notice that there's other stuff going on, and we're able to connect them through those warm handoffs, through introduction to one of the other staff members on the team. Maybe someone comes down to our office for they had a headache, or maybe they come down to see the school nurse who also works out of our space, and they're getting their daily medication. But because we're friendly faces and they know who we are, we end up, students often self-refer. We have an open door policy, so really allowing students to build trusting relationships with our staff. If we sometimes have students who just come down to the health center to say hello, we sort of monitor that because we want them to be in school, we want them to be in class doing what they need to do and where they need to be, but they feel very comfortable and often, stop in just to maintain that relationship. Easy access to school staff and other professionals remains highly important for that whole person client-centered service delivery. If we are missing out on those opportunities to coordinate with teachers, school administrators, parents, other folks, we're not able to provide the same level of service. So we find that, that collaboration is key to ensuring that the students' needs are met on all levels. Being stationed in the school helps us maintain strong partnerships with school staffs. Oftentimes in an outpatient setting, we find that it's really difficult to engage school staff. I don't know if you've ever tried to call a teacher or call a principal working in an outpatient setting or working in a clinic setting, and it's a game of phone tag because everyone's schedules are quite busy. We have the luxury of being able to walk down the hall or being invited into meetings and being in the same spaces and having the same conversations with one another, which ultimately just allows us to, again, bridge that gap between the needs of the student from an educational standpoint, needs of the student from, their perspective, but also from that parent's perspective. And then, ultimately, if we're meeting students' needs across the board, it leads to just better wellness and ability to maintain in their educational spaces. I don't know if you've ever had a headache, if you've ever been sick, if you've ever been feeling under the weather, if you've got major life stressors, it's really hard to show up and do your day-to-day work without taking care of those needs. So being able to have this space for students to come and get those needs met ultimately allows for more time in class and better learning overall. Kind of talked about, there's easy access to a variety of services. Oftentimes students will come to one appointment, they'll come and see your medical provider and be able to, they'll voice some other concerns, and very easy to get on the schedule to meet with our other providers. So getting dental needs taken care of, getting mental health needs taken care of, and vice versa. Talked about reducing barriers and the amount of time that students are out of class. Amy talked about this a little bit, but it takes a lot of time to, if you are going to an appointment in the community, oftentimes mental health appointments occur once a week, once every other week, at minimum once a month, and still that's a lot of time out of class. So if a parent has to leave work, go pick up the student, get them to an appointment, hopefully get them back to school, we're talking about sometimes upwards of even a half day of school missed. So this really cuts down on the amount of time that students are out of class and increases the likelihood that they're going to engage at all. Parents are involved. Parents sign consents. Parents give permission. They're part of our assessment process. They give input around treatment goals, but ultimately, the service is youth-centered. So they really have autonomy to set their goals in therapy. If they don't want to participate, it's not forced. We really try hard to engage them. We really try hard to, help them see the benefits of those things. But ultimately, if they're refusing to participate, if they're not wanting to participate, we will allow them some autonomy to say, like, hey, you know what, not right now, but leaving the door open for when they do need us later. Our team talks a lot about how they genuinely love working with students and they like the school engagement piece. If we don't engage the school, we miss opportunities to engage the students. Super important. When I think about hiring, I think about I need someone with a strong clinical background who really enjoys working with youth and who's going to be a go-getter in terms of wanting to be a part of that school engagement piece and collaborating with school staff. Covered some of those other things, so we can go to the next slide, Donnie. So talking about some of the challenges, as Amy mentioned, we all come from different areas of expertise and different professional backgrounds. And so sometimes that creates barriers to engaging students in our spaces. So we have to focus on understanding teachers' perspective, educators' perspective, administrators' perspective, and helping them to understand where we're coming from in order to get buy-in. If we don't have buy-in from the school as a whole, if we don't have buy-in from a good portion of that community, it's really hard to consistently engage students in the meaningful services that we're trying to engage them in. Our roles require changing hats often and in multiple spaces. So really we have three sets of clients. And, when I talk about the work that we do, we're there to serve the students, but we also, to be effective, need to be able to maintain a relationship with parents and we need to maintain a relationship with school staff. So every case, we talk about kind of smaller caseloads, every case that we have really entails engagement with multiple people and multiple parties in order to do our job well. Sometimes because we have the open door policy and because we create those safe spaces, we have students who like to come down often, and any need that arises, they come and seek our support, which is a really wonderful thing. And also we want to build some independence and helping them build the skills and tools that they need to be able to navigate life in the day-to-day and ensure that we're able to see all the students who are referred to us in a timely manner and making sure everyone gets the space that they deserve. We really need to capitalize on the time in the school day that we have. So I would say we have roughly 5 to 6 good hours a day to see students before they're gone. It's really hard to keep students after school. Sometimes they don't have transportation. Frankly, they don't want to stay after school for things often. When there's testing, when there's spring breaks, summer breaks, holiday breaks, things like that, we see kids wanting to take a break. And even though our services are different, they see us as an extension of the school in many ways and ultimately stop engaging. We're open year round and offer services, but we do see dips in engagement. We talked a little bit about the HIPAA and FERPA kind of differences in confidentiality, and we're all bound to privacy standards, and sometimes the standards look a little bit different between professions. And so there's, kind of a delicate dance that happens between closing out referrals, following up, coordinating, collaborating, and also maintaining, respect for our students and families and maintaining confidentiality and having appropriate boundaries. if we don't do the school engagement piece, if we don't do the parent engagement piece well, we see underutilization in services. So if people are unaware of what we're doing, if they're skeptical of what we're doing, if they're distrusting of what we're doing, it's really hard to steer the students. The upside of us, doing a nice job and seeing kids in school is that we see more kids. The downside of that is that there's still stigma attached sometimes to to seeking services in general. And so sometimes students don't want to be called out of class and have attention called to them, and can be a barrier to engaging with them in a school setting. Next slide. So if you were thinking about, doing this work, some of the tips and strategies for reducing those barriers and addressing challenges, again, would be really engaging. So finding ways to build rapport with staff, students, and parents. I can't highlight and stress that enough. Offering virtual sessions and after school appointments, just for some versatility and to maintain contact and engagement. We try really hard to plan ahead and utilize reminders, especially for students who maybe struggle to find their way to us, even when they're called down, or maybe hesitant to engage, or when they're called down, they get lost on the way to the health center, sort of thing. So really giving reminders to everybody to keep them engaged. Super important to maintain engagement with parents and involve them in their treatment. We have some schools that do this very well, but attending school functions, finding creative ways to capture the attention of all of our audiences. Amy talked a little about this, but the creativity and funding streams, and so that we ensure that all students are able to access services regardless of the ability to pay, insurance, or financial status. And then really becoming a part of that community. So attending sporting events, planning activities during student lunches, having conversations in staff lounges or in the front office, attending conferences or other events really leads to high levels of visibility. And then we have some community advisory and youth advisory committees as well, where parents and students and teachers come together with us and give us input on how to maintain our services. And then some advice for others doing the work, making sure that school staff and health center team are aligned and bought into the mission together. So doing a lot of that work up front before we even get providers in this space, continuing that engagement and rapport building ongoingly throughout our time in their space. Making sure that we're consistent in those efforts. Without consistency, we can definitely see those relationships falter over time and referrals dip, and then we kind of have to start the re-engagement process all over again. There needs to be understanding from leadership that the needs for flexibility and non-traditional schedules is important in these spaces. It doesn't operate the same as in an outpatient clinic model. Team members and leadership should be comfortable maintaining connections with school staff, and leadership should also be engaged in maintaining school-based specific policies and procedures that really support standing up the model for success in the school space.
All right. Thank you all so much. Thank you, Addie. Thank you, Amy. Thank you, Tricia, for that. We do have just a few minutes here for questions. So if you have any questions, please feel free to type those into the Q&A. And then while you're doing that, I did want to just kind of move along a little bit, and we can kind of review the key takeaways and do the poll. But if you do have questions, please type them in. And I also have some from the registration. I think most were answered, but I'm happy to pull some of those as well.
All right. So a lot was talked about today. But I think some of the key takeaways here is really what I talked about in the beginning, right? Is that integrated mental health is not a location or co-location. It's really a system of collaboration. It does require intentional operational design. School context absolutely changes the way in which we coordinate care. And strong partnerships with school staff and leaders are essential for providing services in schools and school-based health centers.
Thank you very much, Addie. So there is one question I think is really good that I wanted to ask that a few people had in the registration. So this is for anyone. Looking back, what's one thing that you wish you had implemented sooner to kind of strengthen your integrated care practices? And anyone can answer that.
Go
I
ahead.
would probably, yeah, go ahead, Trisha.
I would say really talking about, those policies and procedures and the mission of the work and making sure that everybody's on the same page right from the get-go, that this is a team effort to lift off the services. The school does carry a responsibility in the success of the work that we do just as much as we do.
And I was just going to say probably tracking those outcome measures and reporting those out. That has been really helpful.
Great. And then what are the so we just got a question is agreeing with the importance of follow-up in schools. It's hard sometimes with FERPA, but what are your recommendations for that?
Think we are very transparent when we talk about, what we can talk about, what we can't. We work really hard to explain the importance of that coordination and collaboration to everybody involved, so parents, students, and when we're able to, obtaining a release of information. So that really gives us, that go ahead to coordinate care on a bit of a more meaningful level in the schools.
All right. Well, thank you all very much. Thank you for your questions. I am going to open up the final poll. Again, please answer this. It's really, really helpful for us. And while you're doing that, I'm going to do a little bit more and then we'll let you go here. We are having a live conference for the School-Based Health Alliance. It is in DC. We would love to see everyone. Registration is open now. Please, you can go on our website for some more information. These slides will be included with the resources that you can do. It's a great time for collaboration and networking. And you can also stay connected on us. We have quite a few different social media pages. We're here, we're here to interact with you. And if you have any other follow-up questions, we're happy to assist with those too. So with that, thank you all so much for attending this. Thank you for your questions and your engagement. Thank you to our presenters. This was phenomenal. And with that, I will let you all go. The slides and the recording will be posted on our website and within about a week. And you'll also get a few of the resources that we talked about today. All right. Thank you so much, everyone. Have a great day.
Thanks, guys. Hopefully
Thanks,
that was
Tricia.
helpful.